Thank you, Chair. I'll direct this question to the Minister or officials, whoever feels they're best able to answer. There have been some distressing reports in the media of hospitals being either reluctant or, in fact, outright refused.
We just lost your sound there for a second, Senator Paterson.
Sorry, can you hear me now?
Yeah.
Thank you. So I was just saying there's been some distressing media reports about hospitals either being reluctant or outright refusing to accept aged care residents being transferred into the hospital system. I'm interested to understand, has that been occurring, and if so, how widespread has that practice been?
Senator, I'll let the Minister go first.
Thanks, Senator Paterson. Look, there have been some issues in that circumstance. We've been working pretty closely with the Victorian governments and officials, particularly through the Victorian Aged Care Response Centre, to ensure, firstly, that there was capacity within the Victorian health system to accept aged care residents. I think we might have discussed last time the importance of the agreement to see selective surgery to provide and free up capacity. But there have been some reports, both from providers, about a reluctance to accept residents, but that's not only been addressed, it's being managed now through the Victorian Aged Care Response Centre, and there's in excess of 400 aged care residents now in hospital in Victoria, mostly in private hospitals. But the work that we've done, importantly in cooperation with the Victorian Government through DHHS, has assisted us to manage that, because there are times where the availability of hospital beds, not just for clinical needs, but also for facility management purposes, has been absolutely necessary and has been a really important tool for us in assisting a facility with a significant outbreak to actually manage its capacity and the circumstances for the residents.
Mr. Lai, did you have anything to add to that?
I mean, I think the Minister talked about over 400. I think the latest number is 441, and of that group, I think around about 130 of those people are COVID negative. So the private hospitals agreement, which the government entered into with the states, I think on the 13th of March, specifically to set aside capacity to provide this option, has been a really significant tool in Victoria to help with outbreak sites. So the kind of hierarchy of the way in which an outbreak is addressed in terms of hospitalisation is that obviously predominantly public hospitals are used where someone has a clinical need for hospitalisation, and that has by and large been operating as it should, older Australians getting access to hospital based on their clinical need. And then early assessment made around the capacity of a aged care facility to care for residents safely, cohorting and care for them safely on site, and in which case in-reach teams from hospitals are often involved in the provision of that care. And then, but looking with an eye to both the physical layout of a site to say, well, if people can't be safely cohorted, that private hospital provides a way in which that can be safely done, or that if an organisation, a facility is under significant stress, that sometimes it is used as a way to take pressure out of that facility. And that's a key learning from the early outbreaks in Dorothy Henderson and Newmarch, where it is now kind of accepted that to try and achieve a safe level of care in a facility under stress, that hospitalisation option is a really important one.
So just so my understanding is correct, to the extent that this was a problem, it's a historical problem, not a contemporary one. It's no longer occurring. Look,
I think that every day we see a system under stress. As the Minister said earlier, there's a significant number of health workers, in fact, I think a higher number than in the aged care system, who are isolated because they're COVID positive or a close contact, and so that system is under significant stress. And there are occasions where, we've had some occasions where that issue has to be tackled. The VARC, the Victorian Operations Centre, which has DHHS staff, so Victorian government staff, as well as Commonwealth staff, ADF and others, has been a significant step forward in terms of being able to resolve those issues and to make good judgments with all the parties in the one centre. So I think, look, there are definitely isolated cases where we've had difficulty, but I think that Operations Centre is really doing its job in terms of smoothing those occasions over.
That's good, because obviously there's two issues here. One is aged care residents have the same right as any other Australian to access hospital care should they need it, including if they're COVID positive in an aged care setting. But also the other fellow residents in an aged care setting who are COVID negative have a right to remain so if possible, and an early transfer into hospital of a COVID positive patient could help avoid that, couldn't it?
That's right. And look, the judgment's got to be made case by case, because sometimes the right way to achieve effective separation of positive and negative residents is to use hospitalisation of the negative residents. On other occasions, it's you'll have residents with particular behaviours people with dementia who are likely to wander through a facility, and so we take that into account. And so it's very much a case-by-case judgment about how to do that. And you've also got to respect, and this is an issue, I think, another learning from New South Wales, from Dorothy Henderson and Newmarch, making sure that providers have their end-of-life plans or advanced care directives for their residents up to date, so that their wishes can be respected. Because we have had instances where a resident, COVID positive or negative, their wishes are to remain either to remain on site or to take another decision. So we have to respect that.
Understood. And capacity in the hospital system really shouldn't be an issue given the cancellation of elective surgery and given the Commonwealth agreement to effectively enlist the private hospital system as that kind of surge capacity, should it?
I think the stepping down of non-emergency elective surgery in Victoria has, this is how the private hospitals agreement was conceived, and it's working as it was designed, that as the rate of community transmission increased in Victoria, that stepping down of that activity then freed up that private hospital capacity. And we, with the Victorian government and through the VARC, the Operations Centre, we have a line of sight to capacity going forward in private hospitals. So we've got a bit of advanced knowledge about how to place people should there be an outbreak.
Okay, thank you. Moving on to Professor Murphy. Professor Murphy, previously in this committee, I've asked you about the extent to which the effective reintroduction of the virus in Victoria has contributed to this problem. I've been advised that rather than describing that as community transmission, it's more technically correct to say clusters of transmission, so I'll try and do that. But since I last asked you about that, more information has come to light through the hotel inquiry in Victoria about the role that hotel quarantine played in this reintroduction. Could you take the committee through your understanding of that updated information?
Thank you, Senator. So I think there are two issues. One was obviously the hotel quarantine breach and the genomic information that's been released in the Victorian inquiry has indicated that the vast majority, if not all, of the current cases do relate to that quarantine breach. But I think it's really quite important.
99%, I think.
99%, yeah. So I think it seems very likely that this current community outbreak in Victoria is related to that. But there are two aspects to it. New South Wales also had significant seeding from Victoria of a similar extent. And I think the most important lesson of all from the Victorian outbreak for every jurisdiction around Australia is to make sure that they go back and check their public health response. This virus is incredibly infectious, and unfortunately the Victorian public health response was unable to control the outbreaks in the way that New South Wales has done. New South Wales has effectively stamped out what was an outbreak of a similar size to that in Victoria. At the time in May when we collectively as a nation agreed to open up, one of the conditions precedent that I and HPPC were very, very insistent on was that we felt that each state and territory had the capacity to detect and contain and stamp out outbreaks. We knew we would get more outbreaks. We have seen them in New South Wales. They have controlled them. And I think Victoria did everything they could, but this virus got the better of them. And I think the challenge is that every state in the country needs to now look, because the one thing we can do to protect elderly Australians is to not have another outbreak of this size in Victoria. Ever since January, that's what's been driving me. The primary driver of our whole national response has been to stop widespread community transmission, because everywhere in the world we know it has disastrous consequences. So that to me is the lesson learnt. I think every state and territory needs to go back and check to see that they've got all of those systems and processes and to make sure that they can do that. And I do want to pay extraordinary credit to New South Wales, who've had a very, very significant outbreak in the last few weeks, and they have got on top of it. And that's the model for the rest of the country.
Senator Paterson, are you almost done? Had 15
yes, I just want to ask a follow-up question just to explore that briefly, Chair. Thank you. Other than the hotel quarantine failure, one of the clear failures of the Victorian Government's public health response has been contact tracing. There's been some incredibly alarming reports in the media in the last couple of days about this, including on 3AW yesterday, where a caller reported that his mother-in-law was diagnosed with COVID in early July. She died on the 31st of July, and the first sign of a tracing call was on the 7th of August, nearly a week after she died. What has been the differences between the Victorian contact tracing and the New South Wales contact tracing that has produced such radically different outcomes?
Well, I think a reflection on Victoria at the present is that for the last few weeks, they have been overwhelmed. Once you get a transmission where you've got 700 cases a day, no matter how well established and how big your staff are, it's very, very hard to manage that. The challenge was always to have the systems to stop it getting beyond those first 20 or 30 or 50. And I think they have acknowledged that they had system issues and that New South Wales has had a much longer and history of devolved public health response across the system. And Victoria has acknowledged that they have had to do a lot of work they did a lot of work in February, March and April scaling up, and they were pretty confident that they had done what was necessary. But unfortunately, this virus spread so quickly that they've obviously had to do lots more now to make sure that once they're bringing it under control, and it's fantastic, they are bringing it under control now, only 179, I think, cases today. It's finally coming down. But I'd be very confident that Victoria has done huge things now to make sure that a further outbreak will not occur of this nature. It is such a crucial issue.
Okay, just one final clarifying question on that, please, Chair. What is it, though, that Victoria specifically lacked? Was it a lack of qualified contact tracers? Was it insufficient resourcing for the team? Was it bad systems in following up? What have they lacked that New South Wales has? You said something about the devolved structure. What's that?
Well, I think New South Wales structure has had public health teams in every local health district led by senior physicians, and they can have a local response to that. They have had a public health training system. And there are many states and territories like Victoria that don't have as well developed systems as New South Wales. New South Wales is the leader, and I think it is very it's very educational for the whole nation to look at New South Wales and how they have responded, because I think every one of us needs to think that way.
So that decentralised structure is key.
Decentralisation, the number of public health physicians, the IT systems that support it, and that really strong clinical leadership from public health physicians are all important factors in the New South Wales success.
Thank you.
Thank you,
Professor
Chair.
Murphy. Thank you, Senator Paterson.